Hello students, this is Dr. Ways and welcome to your lecture on the lungs. To this point we've kind of hinted around the lungs, but now we're actually going to talk about the lung organs themselves. And the first thing I want you to notice on this slide right here, or this picture right here, is that the right lung is divided into a superior, middle, and inferior lobe. So there are three in total, whereas the left lung is divided into a superior and inferior lobe. And the reason for that is that the heart kind of sits in the middle of the mediastinum and points out towards the left. Because there's less space in the left side of the thoracic cavity, there's one less lobe of the lung to accommodate the heart space, the space that the heart takes up. What separates each lobe are these areas called fissures. So in the right lung, since you have three lobes, you have two fissures. One would be the horizontal or transverse fissure, and notice that is associated with rib 1, 2, 3, 4. So right at about rib 4, mid-sternum, you'll find your horizontal fissure in the right lung. And the other fissure would be the oblique fissure, right, which separates the middle lobe from the inferior lobe. Okay, and of course this is looking from anterior. On the left side, all you have is two lobes, so therefore you only have one fissure, and that is going to be an oblique fissure. Okay, so notice that the oblique fissures are at about the same location on each side. So if this is rib 4, they extend from about the inferior portion of rib 4 down to rib 5, 6. So the oblique fissure goes from about rib 4 to rib 6, downward medially. All right, then of course you should remember down here below the inferior lobes you have that costodiaphragmatic recess that provides space so the lung can expand to its full potential. Or if we're thinking medically, again, we can put a needle in there and draw fluid out if we need to. All right, looking from the back, this slide or this picture right here, notice that we only have superior and inferior lobes. That's because the middle lobe of the right side, which of course here would be on this side because the person's turned around. And of course, these would be continuations of the oblique fissure from the other side because each side has it on the same spot and each side has an oblique fissure in the same spot anteriorly. So those would be oblique fissures. And if we have our patient put their hands above their heads with their fingers interlaced on the back of their head, what you notice is that the oblique fissures in the posterior side line up with the medial border of the scapula. So if you have your patient perform this maneuver and you feel along the medial border of the scapula, what's directly underneath there, of course under the ribs as well, would be the oblique fissure of the lungs separating the superior and inferior lobes on the posterior side. All right, another thing to notice from here is this area right here, which is your vertebra prominens. The apices of the lungs on the posterior side sit just below the vertebra prominens. So you find that vertebra prominens, C7, and you go down approximately 1 unit, you'll be right at the apices of the lungs. And of course, on the anterior side, the apices of the lungs will be in between the first ribs, just behind the clavicles in that space. In clinical correlations, you'll learn where to listen for that when you're listening to lung sounds. In physical exam, one of the measurements you'll be making is the transverse diameter of the thoracic cavity, which is here. So you're going from left to right across the back of the patient, versus the AP diameter, which is the anterior-posterior diameter. All right, and this should be at about a ratio of 2 to 1 in normal patients. So if you find any deviations from that ratio, that could either lead you to ask more questions of your patient or to assume that there might be some sort of long-term respiratory problem that's been occurring. All right, and finally on this, notice that, again, we've talked about where the apices of the lungs are. We've talked about if you put the person in a maneuver with their hands above their heads where you can find the oblique fissures. But also want to notice if the patient is just standing in normal anatomical position, where the fissures start between the two lungs would be at about thoracic vertebrae 4, and they're going to extend downward, traversing between rib 4 and 5. So anything above that would be your superior lobes, and then anything below that down to thoracic vertebrae 10 would be your inferior lobes. So again, if you can, find that vertebra prominence C7 and go down 4 ribs, counting ribs on the backside of the person, you'll be able to find where that border between the superior and inferior lobes is located, and then, of course, anything below that down to thoracic vertebrae 10 would be your uh, lower lobes or inferior lobes. One more thing I forgot to mention on this slide is this note right here, the costal angle should be less than 90 degrees. Now, you're going to see this in your physical exam book next semester. What they are actually referring to is the infrasternal angle. Infrasternal. Or subcostal angle, which you saw from your thoracic wall lecture, and that's this right here. Okay, so what they're referring to at the costal angle is this right here, and it should be less than 90 degrees. And if it's greater than 90 degrees, it could suggest that you've had a long-term respiratory problems such as cystic fibrosis, which kind of gives you a barrel chest appearance, or maybe emphysema that's been going on for a long period of time where your thoracic cavity actually expands and then it will push this angle outwards. Apparently, it can get as far as 180 degrees. So if you see a 180 degree subcostal infrasternal angle, that is a pretty bad sign. When you're listening to lung sounds, you're going to want to listen to multiple spots. All right, so you need to know approximately where these spots are. The first would be in the apex of the lungs, and we've already told you where to find that location. And this picture right here shows where you would place your stethoscope. Notice it's just posterior to the clavicle, between the clavicle and where the posterior portion of rib 1 is. So that's where you listen to the apices. For the rest of the lungs, when you listen to them, notice that it is important that you listen to the intercostal spaces, not the ribs themselves. So if you're listening to the ribs, you're going to have a really dense tissue that's between you and the lungs. But if you go between the ribs and the intercostal spaces, there's only going to be muscle there. Excuse me. So there's less dense tissue to go through, and you will be able to hear it much better. So always make sure that you are between the sternum and the lateral portion of the person in an intercostal space when listening. So you also want to listen to the superior lobes. All right. Notice the superior lobe is about intercostal space 2. All right, just below rib 2. Again, find that sternal angle. Rib 2, go down. There's your second intercostal space. To listen to the medial lobe of the right lung, you go down 1, 2 intercostal spaces to here. So you will be in the 4th intercostal space, right at about the nipple line. You'll be able to listen to the breath sounds of the middle lung, or the middle lobe of the right lung. And then if you go down 1, 2 more intercostal spaces, so look, it's kind of 2 intercostal spaces you're going down each time, and go a little bit lateral, you'll be able to listen to the inferior lobe of the right lung. The same thing applies to the left side, only you won't have a middle lung. You'll still have a superior lobe there. It's bigger than it is in the right side. But you'll still want to listen to that 4th intercostal space because there are airways that branch specifically to that region. Even though there's not a middle lobe, there's still a middle region there in the superior lobe. And then, of course, 2 more intercostal spaces down, you'll be able to listen to, on the more lateral side, you'll be able to listen to the inferior lobes. Of course, that's the anterior side. You're going to want to do the same thing for the posterior side, but in terms of superior middle, inferior lobes. But you want to be careful because you have the scapula right here. So when you listen, you want to listen to it points along the border in the intercostal spaces between the scapula and the vertebrae. All right, so it's going to be real important when you do your physical exam lab to listen to these spaces and not listen over the bones. All right, not shown on this figure, but still important. You'll want to have your patient lift their arms up and at least listen to breath sounds in the axillary region here. So you'll get as close to the superior lobes as you can. And here at about sub intercostal space 6, where you listen to the anterior and posterior sides, listen to the lateral sides too. So both anterior, posterior, and laterals. These are locations where you would want to listen to um, breath sounds and why you would want to listen to in those spaces. So here we see an overview of the respiratory structures and the division between the upper and the lower respiratory tract. So here would be upper, here would be lower respiratory tracts, going from your trachea to your main stem bronchi to your lungs as well. All right. Of course, you have your nasal cavity, and the nostrils, where the air goes through your turbinates here, or nasal concave, where the air is warmed and moistened. And then it goes down here into your nasopharynx, oropharynx, then laryngeal pharynx, down into the larynx. All right. And all of that describes your upper respiratory tract. And once you get into the lower respiratory tract, of course, you have your main airways, your trachea, your right and left bronchi, and then your lungs, which is the purpose of what we're talking about today is the lungs. So we're going to focus on the lower airway, starting with the trachea and then going to the lower and lower airways until we get into the lung tissue itself. So again, I apologize for some of these typographical things that happen in transition to this recording platform. But on this slide, we're focusing on the tracheobronchial tree. So the trachea right here, which goes from your larynx all the way down until it bifurcates into your left and right bronchi. The trachea is approximately 15 centimeters long, which is approximately 6 inches. And notice that it is rings of cartilage. All right, so that gray stuff right there would be rings of cartilage. And between it would be connective tissue. And those rings of cartilage, keep in mind what we showed before was that the esophagus is behind the trachea. So those rings of cartilage are only partially complete. So they form like a C. We call it a C-shaped ring of cartilage. And then in the back is softer connective tissue, so that when food is going down the esophagus and it pushes in, it doesn't break the cartilage, but instead has a soft passage to not cause any damage to cartilage of the trachea when you are swallowing food. Of course, the purpose of the cartilage is to make sure that the airway stays open, kind of like how you have the corrugated vacuum hoses, to make sure that the vacuum hose stays open when you are pulling a large suction volume. Okay, as we split off into the bronchi, we have our right primary bronchus, which is about 2.5 centimeters, and our left primary bronchus, which is about twice as long. Also notice that the right bronchus is much straighter, so it doesn't go as acute of an angle off to the other bronchi, and it's a little bit wider than what you see in the left bronchus. So what that means functionally is that if patients aspirate objects, it's going to be more likely to lodge itself into the right lung than the left lung because of that shorter, wider, and straighter passageway it can go to. It's much harder to get into a passageway that's at more of an acute angle. And you can see that even more clearly on this image right here. The angle versus the width and the length. All right, so those right and left bronchi divide, of course, into our right and left lungs. And then those further subdivide into lobar bronchi. So here would be superior, middle, inferior lobe for the right side. And then here would be superior middle part of superior, and then inferior lobe of the left lung. And those are, again, lobar bronchi because they go to each lobe of the lung. And then from there, they even branch out further. So you get these segmental bronchi going into various segments of the lung. And there is a map of actually all of this that we'll see on the next slide that shows how the lobes of the lung can be subdivided. And this is going to be something that's going to come up in your imaging class in uh, third semester. As you go further down, though, into the segmental bronchi, notice that the cartilage becomes not so ring-like and more diffuse, and there's less and less cartilage and more connective tissue that contains a lot of elastin in it. And so what you'll see is that all of the cartilage is gone by the time you get to the terminal and respiratory bronchioles. And if this is made up of a lot of elastic tissue, of course, these will expand and contract as air is going in and out of them. Then, of course, at the end, you have your functional units of the lungs, which are your alveoli, and that's actually what makes up the bulk of your lung tissue, are those alveoli. And we're not going to go into specifically what they look like. We'll talk about that in physiology and how respiratory gas exchange occurs and the capillaries associated with that. But for now, you go from your bronchi to the bronchioles, terminal bronchioles, respiratory bronchioles, which will contain some alveoli, and then the alveoli themselves, all of which take part in the movement of air into and out of the body and respiratory gas exchange between the lungs and the blood. All right, so this is what I was talking about in the previous slide. When you get into smaller and smaller segments of bronchi, looking at this picture over here, notice that those bronchi go to different segments. So you can, based on the bronchi that are supplying them, divide the lung into further segments to help map where breathing problems might be occurring or where a pneumonia might be located or where a cancer might be located. What I want you to get out of this and what you're going to come across later in a couple of your classes is that the right lung is divided into 10 segments, and the left lung is divided into 8 to 10 segments, depending upon how you combine some of them. So notice here that segments 1 and 2 are combined into one, so that would actually give you 9 segments in this case. So just be aware that there are 10 in the left, or 10 in the right, 8 to 10 in the left. But for our purposes, you don't need to know specifically what the segments are, but be aware that these bronchi branching out supply these segments of the lung, or each lung rather. Okay, so if we look at the medial portion of the lung, we mentioned this earlier, in the space of the mediastinal part of the pleura of the lungs, where there is no pleura, that is where the root of the lung is located. And the root of the lung is where all of the major airways and blood vessels are going to run into and out of the lung tissue. All right, so that's what's called the root of the lung. All right, and a spot where it's indented and those things are coming out, we also refer to it as the hilum of the lung. So the root would be actually all the things that are there entering or leaving the lung, and the hilum would be the area itself. All right, and a lot of times these can, I think, are used interchangeably. So some things to notice. Of course, this is your right lung. This is your left lung. Apex of each lung. Of course, we pointed out the hilum. If we're looking at the medial portion, then this is going to be the mediastinal surface of your lung. All right, which would be associated with the mediastinal surface of your pleura. These would be the bases of your lungs, right? The bases. Notice the base is always wider than the apex. And these would be the posterior borders. So these would be the anterior borders of your lungs, also known as the costal surface. As far as the root of the lung goes, notice that you have the bronchi right here. All right, so here are your bronchi. Here are your pulmonary arteries bringing deoxygenated blood into the lungs, and here are your pulmonary veins bringing oxygenated blood out of the lungs and back to the heart. A couple of other things to notice. If you look in this left lung, you notice that there's an indentation right here, and that indentation should look fairly familiar to you. That is the indentation of the aorta, or what's called the aortic impression. Of course, then right here would be the cardiac impression and the impression for the superior vena cava. Notice that there are other impressions as well. I don't want to go into too much detail about that. If you can recognize the aortic impression, the cardiac impression, and the superior vena cava impression, uh, to tell the difference between the right and left lung, that'll be helpful in and of itself. So this slide kind of shows you a little more detail about those impressions and where they come from. So here's that superior vena cava and the impression that it makes. Here would be a impression from the esophagus, impression from the azygos vein right here, and of course that would be on the right lung. And then of course you see the aorta sitting in its impression, and then the cardiac impression right here. So just to put the organs in place of where we saw some of those impressions on the previous slide. And then at the top here, showing, of course, the superior lobe versus the middle lobe versus the inferior lobe of the right lung. And notice here that the middle lobe sits entirely in the anterior portion of the lungs. So remember, on the back side, you only see the superior and inferior lobes, not the middle lobe, because the middle lobe is kind of uh, relegated to the anterior portion of the lungs. And then again here, superior lobe of the lungs and the inferior lobe of the lungs from the medial aspect. So the bronchi and the bronchioles themselves uh, have their own blood supply. They're not supplied by the lungs. They're supplied by their own blood supply. So you have these bronchial arteries, the right bronchial artery, the superior left bronchial artery, and the inferior left bronchial artery. I don't care that you know where they're coming from, because that's getting into more detail than we need to know. But be aware that there are specific bronchial arteries that go into the lung. Notice they're going into the roots of the lung to supply the bronchioles themselves, because they are living tissue as well, with a blood supply, an oxygenated blood supply. As far as the nervous system goes, or the nervous innervation, we have the sympathetic trunk and vagus branches, because remember, the respiratory system, sympathetic speeds it up, vagus branches are part of the parasympathetic nervous system, so that slows down. And together they make up what's called the pulmonary plexus. All right, and the plexus is just a collection of nerves, and we'll get into some more specific plexuses and have to know what they look like and where they go once we get to the arm and the leg. But for here, just know that the pulmonary plexus has a posterior part. Notice that it is on the esophagus there, and it also has an anterior part, which is on the anterior portion of the trachea, just behind where the aorta is. All right, of course, we have the right and left vagus nerve, which are helping to feed that, and the sympathetic trunk, which is helping to feed the sympathetic portion of that pulmonary plexus. All right, one thing to keep in mind, and I think we're going to talk about this in physiology as well, sympathetic nervous system dilates bronchioles. And if you think about it, that makes sense, because if you are in a fight or flight situation, you want more oxygen getting to your body so that it can get to the muscles, produce energy, and have you, run away or fight whatever it is that is causing you danger. Then a parasympathetic, of course, rest and digest, that will constrict the bronchioles. And it's not going to constrict to cut off your airway, but it's going to take them back down to a normal size for normal breathing, so that you're not always in a heightened state. So it'll calm down the sympathetic dilation of the bronchioles, rather than have a pathologic constriction of the bronchioles. All right, so Why I mention this is it's important to distinguish that from the sympathetic and parasympathetic effects on the vascular system, because remember, in the vascular system, it's exactly the opposite. Sympathetic constricts blood vessels, and parasympathetic dilates blood vessels. Airways, sympathetic dilates, parasympathetic constricts. All right, so the airways and blood vessels have completely opposite effects when it comes to sympathetic and parasympathetic nervous system. All right, and you're not going to be experts in this class, but we want to start getting you familiar with imaging, because, again, you're never going to see the actual insides of your patient. So we have to use surface anatomy and imaging to be able to infer what's going on inside. So if we look at this, of course, this is a body, right? And you know that this is the anterior part of the body, and this is the posterior part of the body, because we see the vertebrae right here. All right, and here are the transverse processes. Here's a spinous process of the vertebrae pointing backwards. So we know that's the back. And what do we know about the back in terms of what we saw in the mediastinum? Well, here is thoracic aorta. Remember, that runs right along the vertebral body here. We have the heart here. Of course, you should recognize this as being in the middle of the mediastinum, or in the mediastinum itself. So that would be the heart, of course. And then these bright spots would be where blood is. So this big one right here would be your aorta. And if it's coming out of the heart, that'd be your ascending aorta going into the aortic arch. And then on the other side of the heart, you'd have your pulmonary trunk. Okay, so your pulmonary trunk right there. And then this, of course, would be where your lungs are located. All right, and if this is anterior, then this would be your right lung, and this would be your left lung, right lung, left lung. And then this, of course, would be your sternum. So again, I'm not going to directly test you on this, but you should start to become familiar with, if I'm seeing an image and I know what anatomy is, I should be able to tell what I'm looking at based on the image that's presented to me. And we're probably going to do some exercises in lab that test you, not for, that will test you on this to some degree. As far as lymphatics go, the only thing I really want you to know is that, just like everything, the pulmonary system has lymphatic drainage to it, and it's going to drain along the lymph vessels coming out of it and into the peristernal nodes that we talked about with the thoracic wall. And of course, that's going to drain into the primarily thoracic duct, and then enter back into venous circulation. All right, and some of it's going to empty into the right subclavian vein as well. So just be aware that there is lymphatic drainage along the peristernal nodes, and ends up dumping in the same place that thoracic duct dumps into, and then some other duct systems on the right side, which we'll get into when we get into the lymphatic system.